Hi, good afternoon, everyone. My name is Keio from Singapore. Welcome to the APSC JCS webinar this afternoon. Today's topic is on heart failure and valve interventions. I'd now like to welcome Professor Issei Komuro, the past president of the Japanese Circulation Society, as well as the president-elect of the Asian Pacific Society of Cardiology, from the University of Tokyo to give the introductory remarks. Prof. Komuro, please.
To start the session, I would like to comment on heart failure pandemic. This is my COI. JROT, a registry driven by the JCS, showed that the number of myocardial infarction patients has been increased from 67,000 to 74,000, 6%, while the number of heart failure patients has been increased from 229,000 to 281,000, 22% for 5 years. Now there are 1.2 million heart failure patients in Japan, and also total population of Japan has been decreasing. The number of heart failure patients is estimated to be increased until 2035. The number one reason of the increase is superaging, since heart failure is a disease of old people. Heart failure is said to be a final stage of all cardiovascular diseases such as valvular diseases, ischemia, and hypertension. Once heart failure is developed, heart failure cannot be cured at present. Thus, following 3 points are very important. First, prevention. To get good lifestyle is the first step, and to prevent the development of lifestyle-related diseases such as diabetes, dyslipidemia, and hypertension is the second step. Second, optimal treatment of heart failure with drugs and devices. Third, research. To cure the heart failure, we should develop the novel treatments based on the mechanism of heart failure. In this webinar 5, 4 speakers will talk about various heart failure treatments, including HFREF, HFPEF, MitraClip, and Tabi. Let's listen.
Thanks very much, Professor Komuro. Now I'd like to introduce our first speaker, Professor Masaru Hatano, who will talk to us about new therapies for heart failure with reduced ejection fraction, overview, effect size, and priority. Professor Hatano is from the University of Tokyo. Prof. Hatano, please.
Can I say this right? Okay. Thank you, chairs and ladies and gentlemen. I'm Masaru Hatano from Tokyo University. So today's my topic is new therapies for heart failure with reduced ejection fraction. This is my COI. This slide shows stages in the development and progression of heart failure and treatment goals by stage. In patients with stage A or B, treatment goals are to prevent the progression of organic heart disease and the onset of heart failure. When heart failure progresses after stage C, so treatment is focused on symptom control, improvement of QOL, and prevention of readmission and death. This slide shows the treatment algorithm of heart failure recommended by JCS and JHFS 2017. In the treatment of HFREF, this guideline recommended SCE inhibitor and ARB, beta blockers, and MRA and diuretics. In Japan, the introduction of new therapies, new therapeutic agents may be a little slower than overseas. So this algorithm does not include ANI or Beveraging. As you know, these drugs are already available in the US and Europe. Both ACC/AHA and ESG guidelines recommended Beveraging for patients with sinus rhythm, LVEF no more than 30%, and the resting heart rate no less than 70 BPM, despite maximally tolerated dose of beta blockers. However, there are some differences between the ACC/AHA guidelines and ESG guidelines. Although ACC/AHA guidelines recommended specific beta blockers such as bisoprolol and carvedilol, and ESG, on the other hand, ESG guidelines gave only class recommendation for SE inhibitor, ARB, or beta blockers. There are also some differences in the recommendation for ANI and Beveraging between the two guidelines. However, in these two guidelines, the recommendations for ANI and Beveraging are consistent for class 1 and class 2A respectively. At first, I would like to talk about ANI and Beveraging, which are already widely used in the US and Europe. Valsartan sacubitril combines the angiotensin receptor blocker valsartan and the neprilysin inhibitor prodrug sacubitril in the 1.1 to 1 ratio in sodium supramolecular complex. Sacubitril is a prodrug of neprilysin inhibitor. The enzyme responsible for the degradation of the natriuretic peptide and many other vasoactive peptides. Thus, this combined angiotensin receptor antagonist and neprilysin inhibitor address two of the pathophysiological mechanisms of heart failure: activation of the renin-angiotensin aldosterone system and decreased sensitivity to natriuretic peptides. This slide shows the result of Paradigm HF. This study was enrolled 80,442 patients which class 2 to 4 heart failure and EF no more than 40% to receive either ANI or enalapril. In addition to recommended therapy, the primary outcomes was composite of this from cardiovascular cause or hospitalization for heart failure, but the trial was designed to detect the differences in the rate of death from cardiovascular causes. As a result, at the time of study closure, the primary outcomes had occurred in 21.8% in the ANI group and 26.5% in the enalapril. 20% risk reduction was obtained by ANI. So this study revealed that ANI was superior to enalapril in reducing the risk of death and hospitalization for heart failure. This slide shows the effect of sacubitril valsartan according to etiology of heart failure. The benefit of sacubitril valsartan over enalapril was not modified by etiology because there was no significant interaction according to etiology. Next topic is Beveraging. This slide shows a schematic diagram of the mechanism of action of Beveraging. SAN cells are primarily responsible for initiation of electrical impulse and frequency of spontaneous action potential firing determines heart rate. SAN cells codes show diastolic depolarization generated by inward ionic currents from the orchestrated work of ionic channels, the so-called membrane clock. Beveraging inhibits IF to decrease the rate of slow diastolic depolarization, which leads to reduced heart rate. This slide shows the result of SHIFT trials. This trial was enrolled with patients with LVEF no more than 30% in sinus rhythm with heart rate no less than 70 ppm, admitted to hospital for heart failure within the previous year, on stable background treatment, including a beta blocker, if tolerated. The primary endpoint was the composite of cardiovascular death or hospital admission for worsening heart failure. As a result, 24 patients in the Beveraging group and 29% of those taking placebo had a primary endpoint event. 18% of risk reduction was obtained by Beveraging. In terms of underlying disease, ischemic etiology tended to less effective than non-ischemic etiology. In addition, the group with a baseline heart rate no less than 77 was more effective than the group with a baseline heart rate of less than 77. So, clinical trials of Beveraging for Japanese patients was enrolled patients with heart rate no less than 75 beats in sinus rhythm. And Beveraging was studied at 2.5 milligram twice daily because the incidence of phosphonates was high in Beveraging group at the starting dose of 5 milligrams. Due to the small number of cases, there was no significant differences in primary endpoint in this study, but it was significantly less in the Beveraging group in hospital admission for worsening heart failure. And next, I'd like to talk about the drugs that will be used in the near future. Now, SGLT2 inhibitor is recommended as a drug for preventing the onset of heart failure in diabetic patients with a history of cardiovascular disease. As you know, the Empire outcome study is one that SGLT2 inhibitors have gained this position. This study revealed that patients with type 2 diabetes at high risk for cardiovascular events who received empagliflozin had a lower rate of the primary composite and cardiovascular outcome and death from any cause when study drug was added to standard care. Based on this study, SGLT2 inhibitors were expected to have potential as a drug for the treatment of heart failure. As you see in this slide, DAPA-HF was a phase 3 placebo-controlled trial. 4,744 patients with NYHA class 2 to 4 heart failure and LVEF no more than 40% received either dapagliflozin or placebo. In addition to recommended therapy, the primary outcome was composite of worsening heart failure or cardiovascular death. As a result, dapagliflozin reduced the composite of worsening heart failure or cardiovascular death by 26% compared with placebo group. Moreover, the result of Emperor reduced trial using empagliflozin will be published in Issei 2020 held next month. Today's last topic is Beveraging. Beveraging, a novel oral solid guanine cyclase stimulator like Hayashida, enhance the cyclic GMP pathway by directly stimulating soluble guanine cyclase through a binding site independent of nitric oxide. And it sensitizes soluble guanine cyclase to endogenous nitric oxide by stabilizing nitric oxide binding to the binding site. This slide shows the result of the Victoria trials. This study was a phase 3 randomized double-blind trial, placebo-controlled trial. This trial enrolled 4,050 patients with chronic heart failure to receive Beveraging or placebo, in addition to guideline-based medical therapy. The primary outcome was composed of death from cardiovascular causes or first hospitalization for heart failure. As a result, over a median of 2.8 months, a primary outcome event occurred in 35.5% in the Beveraging group and 38.5% in the placebo group. 10% risk reduction was obtained by Beveraging in this study. This slide shows a primary outcome in prescribed subgroups. This result is difficult to interpret. For patients with high NT-proBNP level, Beveraging might not be efficacious. In conclusion, both types of drugs with novel mechanisms of action have become expected to be available as therapeutic agent for heart failure. Although positioning of each drug is topics for future study, any seem to be effective for both ischemic and non-ischemic etiology. Beveraging appears to be particularly effective in non-ischemic etiology cases and cases with heart rate no less than 75. Beveraging should be started at 2.5 milligram twice daily to prevent the onset of adverse effects. The position of SGLT2 inhibitors having the diuretic effect will change depending on whether they are effective as therapeutic agents for heart failure that exceed their diuretic effect. Regarding Beveraging, it is a future task to clarify the patient image for which it is effective. Thank you for your attention.
Thank you, Professor Hatano. Let me see whether maybe I can make a general announcement about Q&A to the audience. At the bottom of your Zoom platform, you will see a Q&A button. Please use it to put your questions. If you have it in English or Japanese, we will be able to answer them. Maybe just to get the ball rolling, I would like to ask Professor Hatano some questions regarding his remarks regarding the new drugs. Can I check with regards to the dapagliflozin and Tresto, valsartan's cubitril? If you had a choice, which one would you start first and why?
SDC altitude effect inhibitor, I think will be widely introduced for many patients because they have diuretic effects. So I'm not sure in which timing should SGLT2 inhibitor will be introduced before loop diuretics or after the diuretic? I don't know, most patients will receive a combination with loop diuretics and SGLT2 inhibitors. So, regarding the ANI, ANI is now supposed to be used by switching from SCE inhibitor or ARB, but ANI is proved to superior to SCE inhibitor or ARB. So in the future, it will be an option to introduce ANI before introduce SCE inhibitor or ARB, I think.
Thank you very much. Can I ask the other panelists and my co-chair whether you all have any questions as well? Yes, Prof. Komuro.
Can I ask a question for KK? To
Yes.
KK? Because we have not used ANI or Bersiguat yet. Have you ever used ANI or Bersiguat already?
Yeah, well, we have the ANIs already, but not Vericiguat, at least not in routine clinical use. I think some of my colleagues may have used it in research settings. But for Entresto, we have used it, and it has been very effective. It's a very powerful drug. I think the main concern is in patients who have a borderline blood pressure. But in the patients in whom I have had a chance to use it, it is remarkably effective. I'm actually quite impressed by it. I think the main concerns relate to its hypotensive effects, and also in patients with an underlying renal impairment. I think there's a bit of there has to be some caution applied. Lastly, it remains expensive, so some of our patients who can't afford it, we have to make some arrangements for them to get some support from the government. But I would say that in my patients, especially those whom I would consider even more aggressive forms of therapy like the MitraClip, I would definitely put them on Entresto first, just to make sure that we have put in a reasonable effort to put them through guideline-directed medical therapy.
So I think you would change from ACE inhibitors or ARB to ANI. So what patients are candidate to change from ACE inhibitors to ANI?
In my practice, as long as they continue to have significant symptoms, I would recommend changing. I think that has to be balanced against cost as well as the risk of non-medication compliance. So if I have a 75-year-old who doesn't go out of the house much, and although may have class 2 symptoms, I may choose not to convert them to an ANI if they have been stable and they can go to the market. That may be good enough for them, especially if I know that cost is a concern. On the other hand, if I have a 50-year-old and continues to work and needs to go to work and has significant symptoms, I may escalate to an ANI because the benefit to the patient may be more. So I think it has to be customized to the individual patient. I hope that answers the question. But I think as this field will continue to evolve as we get more data, and as well when cost comes down. Now there is a question from the Q&A, and allow me to read this. This perhaps is directed at Professor Hatano. It says here, in the conclusion, it is said that the SGLT2 inhibitor can be a diuretic. So if a patient given an SGLT2 inhibitor in the clinic, is it necessary to adjust the diuretic dose? And how should we monitor the electrolyte imbalance? Maybe I'll leave this to Dr. Hatano to.
I don't know, but if patients with mild symptoms of SGLT2 introduction of the SGLT2 inhibitor is rather better, seem to be better than introduction of diuretics. So SGLT2 inhibitors have a potential of risk reduction of heart failure events. So I think the SGLT2 receptor inhibitors have for not only the diuretics, but also to prevent the event of heart failure readmission.
So probably time is up. So let's move on to the second speakers. Is it okay, Professor Keio? Okay, thank you very much, Dr. Hatano. The next speaker is my co-chairman, Dr. Keio. He is from the National Heart Center, Singapore. The title of his talk is MitraClip for MR, Overview in Asia.
Thanks, Professor Komuro, and thank you very much for the opportunity to speak today. Today's topic is on the use of the MitraClip and an overview in Asia. These are my disclosures. So the MitraClip device, as shown in this slide, has multiple components. It is currently been deployed in the United States, Europe, Australia, New Zealand, as well as many parts of Asia. Currently, it is indicated for degenerative mitral regurgitation in patients with high surgical risk, as well as in functional mitral regurgitation in severely symptomatic patients who remain symptomatic despite guideline-directed medical therapy. On the right panel, you see the various components of the device. It is a rather complicated device with multiple parts and require the use of a stabilizer and a stand in order to keep the device in place. The first implant was in 2003, and currently it has been implanted in more than 100,000 patients worldwide. I want to maybe look back to the title of today's webinar, which is on heart failure and valve therapies, and perhaps the paper that has so influenced the use of this device is the Coabs study. And I want to highlight that the primary effectiveness endpoint, which is all hospitalizations for heart failure within 24 months, was dramatically met with the MitraClip in combination with GDMT, showing a hazard ratio of 0.53, which is a pretty dramatic outcome for a device intervention for heart failure. And in this, the number needed to treat is 3.1 in terms of the annualized rates for heart failure admission. Now, what is also important for this particular study is that all-cause mortality in the MitraClip arm was also dramatically improved with a number needed to treat of 5.9. Now, I would perhaps say in a provocative manner, for discussion, of course, that compared to the preceding studies as discussed, whether it is a DAPA-HF or the paradigm studies, this number to treat is very remarkable. Now, back to the MitraClip. This device has been in use since in clinical use since 2008, first in Europe, and there are multiple randomized controlled trials. And right now, more than 100,000 patients. This slide is already old. You can see that at that point in time, there were more than 17,000 patients enrolled in the various clinical research studies. Worldwide, as I've said, more than 100,000 patients treated, and in Japan, more than 2,000 patients treated since it was used first in slightly more than a year ago. Now, this paper, which we published earlier, late last year in the Circulation Reports, was an overview of the use of the MitraClip in Asia. And you can see here that the uptake of the device has been gradual, and I'll give a few comments as to why that has been the case. Of course, in 2018, starting in April the 1st, the MitraClip was first used in Japan, and since then the numbers have skyrocketed, largely because of the number of because of a reimbursement availability in Japan and the lack of it thereof in other countries in Asia. Now, these are some of the key milestones for the device in the Asia Pacific region. We first started using it sometime in April 2011, but you can see that the Australians beat us to it with the Sir Charles Gardner Hospital starting its use in March 2011, and thereafter the rest of Southeast Asia, Taiwan, as well as other countries started using it. And the only country as of the publication in 2019 was with reimbursement was in Japan. I believe this was Dr. Matsumoto's hospital in Sendai, Kosei, which had the first case on the 2nd of April 2018. India had some limited use, and so in China as well, but these were very limited cases on a special use basis. There have been a number of publications in the region as well. I think Australia published a series of their initial cases of 25 patients. Within the rest of Asia, we also have a combined registry with Australia, China, Indonesia, Malaysia, etc., that had published a case series of 142 patients. The Japanese AVJ trial enrolled 30 patients, and then there is a series out of Taiwan as well. Now, I want to highlight that in the mix in this particular series, except for the Australian series, the majority of the studies had a fairly equal mix of degenerative and functional MR, whereas in the Australian series, these were largely functional mitral regurgitation patients. The age range were largely in the elderly cohorts of patients, with most patients in their 70s. Of course, in Japan, with the super elderly, you have patients who were treated in the 80s. Now, the other important fact that I wanted to highlight is that if you look at the acute procedural success of the Asian cohorts in Australia, China, Indonesia, Malaysia, and Singapore, the acute procedural success was approximately 94%, and in the other studies were roughly around the same. Now, this is reflective of the initial experience that we have in Asia, and this is comparable to the Mitra Swiss or the initial European results, as well as the initial early American experience. Now, of course, now with experience, many of the acute procedural success rates have improved, but early on, these range about 90%. This is the original publication that we had out of the MAS, the MitraClip Asia Pacific Registry. As you can see, this spans many of the countries in Asia and represented our early experience. But I'd like to take a bit of time to share with you all what was published from the Japanese approval study. This is the AVJ 514 study, which was published in a Circulation Journal back in 2018. You can see that they had 30 patients. And in this particular case, again, this is very important because the initial device time, which is the time that it takes to get across the interatrial septum to the deployment and withdrawal of the guide, is about 2 hours. And this is representative of what it is to do such a procedure and the initial learning curve for such a complex procedure. The initial implant rate was 100%, and depending on the strict criteria that we had, which was to have an MR reduction of less than to 2+ or less, the acute procedural success is 86%. And this is consistent with the worldwide experience, including the experience in the rest of Asia. But what is important is that despite the acute procedural success of 90% or so, that patients had a marked improvement in MR severity scores as assessed by a core collab in alcohol echo collab, both at discharge and at 30 days, with the majority of patients having the MR reduction to 1+ to 2+. Furthermore, there was NYHA functional class improvement. As you can see, at baseline, most patients were in class 2 and class 3 NYHA class heart failure, and this improved to class 1 and class 2 for the vast majority of patients. And this was the basis for approval for the use of the MitraClip in Japan. Now, this is a complicated slide. I just highlighted it to show that whether it is degenerative MR or functional MR, there really were no significant differences in terms of effectiveness. And the MitraClip, consistent with results from the MARS registry as well as worldwide data, suggests that the MitraClip is effective in both degenerative and in functional MR. Now, what are the challenges in Asia? Well, the device remains expensive depending on which country. Prices can range from 25 to 30,000 US dollars, and that there remains a lack of national reimbursement in most countries, with the exception of Japan. I think the device has just recently been launched in Korea, although I'm not sure. I don't think it's reimbursed yet, but I could be wrong there. The regulatory approval for its use remains pending in China and India, although in India you can use it for compassionate use in the very selected cases currently. In Asians, we think that there are some unique challenges in terms of perhaps smaller atria, as well as possibly smaller blood vessels. Talking to my colleagues in this area, I understand that there have been rather interesting complications with such as a rupture of the inferior vena cava or the iliac veins with the large 24 French MitraClip device. So these are unique challenges arising from the smaller body surface area in our Asian patients. Now, I just want to share a little bit about our experience in heart centers in Singapore. As you know, we started the device use in 2011, and numbers have been fairly flat at about anything from 7 to maybe about 12 or 13 cases a year. Last year was a bumper year. We had 25 cases, and this year we have been fairly similar to last year. I think we may hit 25 as well this year, but the numbers are constrained largely by cost and the fact that surgery remains a very attractive option for patients with degenerative MR. These are some of the key patient characteristics. I just want to highlight again that the majority of patients are in their 70s, and that these are patients at high surgical risk with high logistic Euroscore or Euroscore 2 or STS scores. Most of our patients are in class 3 heart failure, but they range from class 2 to class 4. Now, peculiar to this region, as opposed to, say, Europe, the most majority of our patients are degenerative MR, unlike in Europe where the majority of patients are functional. And perhaps this reflects the fact that currently the majority of our referrals come from cardiac surgeons in patients who already meet indications for surgery. The acute procedural success is again has improved with time. It is now about 97%. But what is interesting is that at 1 year, our mortality is close to 20%. Now, this is not that surprising if you look at Coabs study. The Coabs study for functional MR, the 1 year and the 2 year mortality rate is approximately about 20%, and then at 2 years about 29%, even with the MitraClip. So these are sick patients we are treating, and the data from our own retrospective data registries confirm that. Now, what we have also done is that we have taken out some of these what we call salvage cases, where patients come to us in cardiogenic shock or already with end organ perfusion injury. And even though we take out these salvage cases, the mortality rate remains high at 1 year with about 16.5%. So I think we still have some ways to go before we can fully select the best and most suitable patients for this therapy. What is the impact of COVID on the MitraClip in Asia? Well, I think service levels have been affected as hospitals cancel electives. I understand from some of my colleagues in Southeast Asia that they were not allowed to do MitraClip at all, and the hospital loading was such that only the acute MIs were treated, for example. The evaluation and workflow was affected. For example, TEE and CPET studies were constrained. Physician proctoring was affected. I was supposed to proctor some cases in other parts of Asia and I couldn't travel. And the clinical proctor from Abbott couldn't travel either. And of course, training for new technology will be affected. For example, my proctors can't get trained for TriClip. So in summary, I want to conclude by saying that the MitraClip is the first transcatheter mitral valve repair device. There has been wide adoption across the world and in Asia. Rising adoption in Asia is seen, but this is hampered by reimbursement issues, volume, and experience. There is clearly a role for high surgical risk, severe degenerative mitral regurgitation, and there is now with the Coabs study a role for symptomatic severe functional mitral regurgitation in patients who remain symptomatic despite a reasonable guideline-directed medical therapy. Thank you.
Thank you very much, KK, for our excellent review on MitraClip. So KK's paper is open for questions, comments. Are there any questions? So KK, how do you decide surgery or MitraClip?
That's a very good question. In general, we have a heart team, and the heart team will include cardiac surgeons as well as heart failure specialists. In our current team, we have 2 heart failure specialists as well as at least 3 surgeons. And so for degenerative mitral regurgitation, I think most times if a patient is suitable for surgery, we will refer for surgery. And the majority of my degenerative MR cases are actually referred by the surgeons. After the surgeons feel that surgery is not suitable, they will refer to us. For functional mitral regurgitation, it is a lot more challenging because the challenge is actually in deciding the timing of offering the clip. Because we could put the patient on Entresto or put the patient on dapagliflozin and maybe consider the patient for left ventricular assist devices. But the exact timing is much, much more difficult to decide. And we often have patients refer to us by the general cardiologist that we will then put through the heart team for discussion before we offer the MitraClip.
Okay, thank you. So, Dr. Chung, Dr. Hang, do you have questions?
Not so far. Thank you.
How about Dr. Hayashida?
Hi, Kentaro.
Hi, KK. Thank you for your excellent talk. I really enjoyed it. So what do you think is the biggest challenge to prevail the MitraClip in Asia? So of course, we have the financial issue, but we also have some other issues. So what is your thought?
Well, I think some of these challenges relate to the nature of the technology. Currently, in order to use this technology, you require very good transesophageal or echo imaging. Secondly, you require general anesthesia. And lastly, the device itself is bulky. So I would say that, for widespread adoption, we would need improvements in the technology to allow maybe smaller French size equipment, and that perhaps the device may have a higher tolerance such that we don't need such aggressive and complex imaging. So if these two are met, then potentially this technology can reach more patients. I would say that the other major thing that is required is that we will require data to compare, much like in Tabi, in normal risk patients. And I think that in the West, there are already trials ongoing to study that particular cohort of patients.
Thanks.
Mm-hmm. Okay, any other questions? So no more. Okay, let's move. Thank you very much, KK.
Thank you very much. It is now my pleasure to invite Professor Kentaro Hayashida from the Keio University School of Medicine in Tokyo to give us a talk on Tabi, ready for low-risk patients. I'm looking forward to hearing this, Kentaro.
And thank you, KK, Thank you, Kiki, for your kind introduction. Can you see me and can you hear me? Okay, perfect. So let's start. And so actually, my talk is about Tabi ready for low-risk patients. Actually, the low-risk patient is approved in United States and Europe, but we today are thinking of what is the optimal candidate for Tabi. And first of all, Tabi was firstly performed in France by Dr. Alain Cribier in 2002, but it has already been 18 years so far, and many patients are already treated with this technology. At the beginning, the indication was only limited to high risk or inoperable, but in 3 years ago, there was some publication about intermediate risk patient, and like Partner 2 or Evolute Coabs intermediate risk trial. So intermediate risk patient is approved in Europe and United States in 2017. And if we look at the growth in terms of number of Tabi in Europe, you can see the significant growth in terms of the number of Tabi in Germany. And the blue one shows isolated surgical ABR, and the red shows the surgical ABR with bypass surgery. So Tabi has the great increase in Europe. And we can also see the same increase of TAVR procedure in United States. So that means the Tabi number is increasing year by year. And I'd like to introduce some result from the Partner 3 trial, that is the low-risk trial. And 1,000 patients are randomized to Tabi, either Tabi or surgical ABR. And 10-year follow-up is planned now. And most patients are enrolled from the North America, but the 3 Japanese centers, including our hospital, also joined this trial. And we need to know the key exclusion criteria: bicuspid valve, severe AR or MR, AV dysfunction less than 30%, and severe calcification, which is not suitable for Tabi, and the poor vascular anatomy, and the complex coronary artery, and the low coronary takeoff, which might have the risk of the coronary occlusion. And this is the primary endpoint at 2 years. And TAVR still demonstrated the decreased composite endpoint compared to surgical ABR. And this trial also demonstrates death and disabling stroke. Even at the 2 years, there was no significant difference between 2 groups, even though there was significant difference at 1 year. And there was significant difference between 2 groups in terms of rehospitalization. So that means the advantage of TAVR continues through 2 years. And echocardiography demonstrated the slightly decreased mean pressure gradient with TAVR, with surgical ABR compared to TAVR due to the annular enlargement surgery. That means the surgeon did a really good job in this study. And these are the secondary endpoints. And new onset AF was decreased in TAVR and new LVBB as well. But the valve thrombosis was was higher in TAVR compared to surgical ABR. And if you look at the data from the Evolute low-risk trial, this is the primary endpoint. There was a trend towards decreased death and stroke at 1 year with Evolute compared to surgical ABR, but it was not significant. And this endpoint is the same as what the Partner 3 trial has, and there was significant difference between 2 groups. That means the 2 independent randomized control trial demonstrated the same result. And with Evolute R devices, hemodynamic was superior with TAVR compared to surgical AVR due to the superior mechanism of the Evolute R device. And prosthesis patient mismatch was the less noted in TAVR compared to surgical AVR. That means if the patient has big body and small annulus, the TAVR with superior device could be beneficial compared to surgical AVR. And this is the KCCQ, that is the criteria for the QOL. And TAVR has the a quicker recovery compared to surgical AVR. And if you look at the death and stroke at 30-day, both Proton 3 and Evolute low-risk trial demonstrated decreased incidence of these endpoint with TAVR compared to surgical AVR. That means the two independent randomized controlled trial demonstrate the same result. Based on this data, FDA and Europe approved the low risk for Tabi, but not yet in Japan. So what is the remaining issues? The valve durability, of course, is a remaining issue. We have the 10 years of the durability data with TAVR, but not for the longer data. And the low risk doesn't mean young patient. That is also very important. And leaflet thrombosis and optimal antithrombotic regimen is also very important. And pacemaker and PVA remains issue. And the coronary access after Tabi is also a very big issue. And there was some unsuitable anatomy for Tabi procedure, and concomitant mitral tricuspid coronary disease is also very important. And the patient and hemodynamics is not the candidate for Tabi in Japan, and it would be awaited in the future. And cost effectiveness and surgeon's involvement is also very important. And we had the major update on the guideline on variable heart disease this year. And finally, STS score was excluded from our Japanese guideline. That is really big news for all of us. And leaflet thrombosis is also very important. That is published in 2015. And we find this kind of the black one, that is the leaflet thrombosis. It might affect the motion of a leaflet. And we need to know the natural history, and we also need to know the optimal antithrombotic therapy. If we find this kind of the hyperattenuated leaflet thickening, usually we start warfarin, and then we usually find a resolution of hyperattenuated leaflet thickening. And if the patient are on anticoagulation, usually we have the lower incidence of thrombosis compared to DAPT or SEPT. That means the additional clopidogrel doesn't impact the incidence of the hyperattenuated leaflet thickening. And this health leaflet thickness might impact the increased incidence of TIA, but we need to know more and more data. We also published some data from our Ocean Tabi registry. And in our registry, it didn't impact the composite endpoint during the follow-up of 2 years, but we need to have more and more data in the future. And clinical questions are routine CT screening after Tabi is required, maybe not recommended due to the patient has the renal dysfunction and radiation or cost. And routine anticoagulation after Tabi is required, maybe no, because of the higher bleeding risk in elderly cohort. Maybe it will work in the future, but the Cardiology trial was negative. And potential impact on durability in the future, we need to have more and more data. And recent popular Tabi trial demonstrated that the clopidogrel increase a death or cardiovascular event. That means if the patient has atrial fibrillation, we can start only anticoagulation. So we don't need to put the additional clopidogrel. That is also very big news for the patient. And this is the MPH Tabi AF trial driven by Daiichi Sankyo. And if the patient had atrial fibrillation after Tabi, the patient are randomized to edoxaban or warfarin. And our Ocean Tabi group was a part of this trial. And this is Atlantis trial. That is the also randomized control trial. If the patient have atrial fibrillation, the patients are randomized to either warfarin or apixaban. If the patient doesn't have the atrial fibrillation, they are randomized to apixaban or DAPT or SEPT. We're going to have the data maybe this year. And durability data is also very important. This UK TABI registry demonstrated the good 8-year durability data with TABI. And the recent publication from Vancouver demonstrated the very good durability data. During the follow-up of 10 years, we only saw the 6% of structure valve deterioration of TABI devices. That is also really good data and equivalent to the surgical valve data. And if you look at the hemodynamics during follow-up, there was no significant difference between post-TABI and 10-year follow-up as well. And our Ocean TABI registry also demonstrated some data. This is the clinical free score. This score very easily represents patient frailty. If the patient has the very severely frail or very severe frail, the patient prognosis is much worse than other cohort. That means if the patient are too frail, we need to rethink about the indication of TABI procedure. And cognitive impairment also might impact mortality after TABI. So we need to be also careful with the cognitive impairment of the patient. And prosthesis patient mismatch is also a very important topic with small annular patient. But notably, we only see 0.7% of severe prosthesis patient mismatch in Japanese patient. On the other hand, in the United States, 10% of severe PPM was noted. Maybe we have the lower number of severe PPM due to our smaller bodies as compared to Western patient. And we started from 8 centers, now we have 25 centers so far. And this kind of the AVOT classification is also the unfavorable anatomy for TABI. So a newer generation devices like Lotus Valve could also be the solution for this kind of patient. And if we treat the younger patient like 60s, we usually start from surgical ABR and then TABI in sub. But in their 80s, we need to rethink about the intervention of this kind of patient. Second TABI or reduced surgical ABR, that is also a very important point. And what do you think of the starting from TABI in their 60s? We might have the first surgical ABR in the 70s and the TAB in sub in their 80s. That is also the paradigm shift in the future, but not the default strategy for the current situation. And some people are thinking about TAB in TAB or TABI 3 times of TABI, but we also need to have the more and more data if we proceed to this kind of direction. And coronary access after TABI is also very important. As far as we put the smaller valve is okay, but if we put the taller valve with suprannular position, it might impact the future coronary access. And if we put the second TABI devices, and the shorter valve is okay, but if the valve is tall, we cannot access coronary anymore. So we need to have the good strategy for TABI if we really treat the younger patient. And in conclusion, ladies and gentlemen, RORIS trial demonstrated better short-term outcome of TABI over SAVR, but the follow-up is only 2 years, so we don't have the long-term data yet. And these patients are excluded from the study by bicuspid valve, severe coronary artery disease, LVOT calcification, or march valve disease, etc. So we think we need to know the exclusion of these studies. So our remaining issues should be durability, future coronary access, liver thrombosis, multiple disease, pacemaker, and so on. So need to think about it. So I think the heart team discussion is of utmost importance to provide better treatment for the patient. Thank you very much for your attention.
Thanks, Kentaro. That's a very, very nice overview for Tabi. I have a question with regards to your experience and the experience in Japan. I saw at the Tokyo Valves, I think it was last year, that some centers have begun to work on TEVI under local anesthesia.
Yep.
Is that, common practice in Japan now?
So actually, in some centers, it's totally the default strategy. For example, in our hospital, we studied local anesthesia from 2016, and most of the patients are treated under local anesthesia. But some centers, maybe only 30 centers are doing local, and 70 centers are still doing general anesthesia. But general anesthesia also have the advantage to have the transesophageal echo and easy control by anesthesiologists. So it totally depends on the expertise of each center, I think.
Thanks very much. Other questions from the other panelists and chair? I have another question for you, Kentaro. I mean, or actually, Dr. Hong, I think you have a question. You have a question?
Yes. Dr. Kentaro, thank you for your wonderful review. I have two questions. First one is that based on the heart failure team point of view, would you routinely do the stress echo for those presenting the low pressure and the low cardiac output LT valve stenosis patient in clinical practice? That would be time consuming, or would you just do a routine rest echo? And the second one, that as you mentioned, I think that could be some patients suffering from multiple valvular disorders, like they may presenting with mitral valve stenosis as well, or tricuspid valve regurgitation. And in your practice, how would you solve these problems? Would you combine the surgical correction with the Taiwan, or would you just simply deal with the aortic valve stenosis? Thank you.
Okay, thank you very much for your great question. So actually, for the mitral valve disease or concomitant TR or mitral stenosis, we also think about the surgical correction. And recently, we published some guideline on the valvular heart disease, and we used the ESCD guideline model. And we propose some TAVR favor factors and the surgical AVR factors. And finally, we take all the factors together, and the decision will be made by heart team. So I think this kind of the concomitant valvular heart disease could be the favoring factor for the surgical AVR, I think. And your first question was, could you repeat your first question?
Yeah, I mean that some patient may have low cardiac output and low pressure aortic valve stenosis. And would you routinely do the stress echo by your clinical practice?
Thank you. And actually, for the low flow, low gradient patient, it's really important to make good diagnosis, correct diagnosis. And if the patient has a classical low flow, low gradient with the reduced ejection fraction, we routinely apply WTM stress echo. And if the patient has a true AS, should AS. But sometimes the patient might have the concomitant coronary artery disease, and sometimes it's risky to do the WTM stress echo. So we also take into account the calcium score by CT scan or patient symptom as well.
Thank you very much, Kentaro. I think this is a very nice conclusion to the session. I will let Professor Komuro close the session. Professor Komuro, please.
Yes, thank you, KK. As I mentioned in the introduction, heart failure is a big problem all over the world. include Asia. In a session for speakers, talk about heart failure from the various aspects, such as HFREF, HFPEF, MitraClip, and Tabi. I believe everybody enjoyed the excellent talk. So I would close this session by saying thanks to all speakers and all audience. Okay, thank you very much.
Thank you so much.